The human hand is an incredible and intricate structure that plays a vital role in our everyday lives. As the functional unit of the upper limb, the hand is responsible for a wide range of activities, including gripping, manipulating, and communicating. Its remarkable complexity and versatility allow us to perform both fine and gross motor movements with incredible precision and dexterity. The wrist joint, or the joints between the bones of the forearm and carpus, are covered by many ligamentous structures to stabilize it. At the distal radioulnar joint, that is the joint between the distal end of the radius bone and the ulna bone of the forearm, an important anatomical structure is found here. It is known as the Triangular Fibrocartilage Complex. Here you can see the ulnar, radius, lunate, and triquetrum. The highlighted area is the Triangular Fibrocartilage Complex. The nomenclature, Triangular Fibrocartilage Complex, is apt because it reflects both structure and anatomical shape. So, Triangular Fibrocartilage Complex, also called as TFCC, is an important set of structures located at the distal ulnar aspect of the wrist. It serves as the primary stabilizer of the distal radioulnar joint, DRUJ, and bears weight as well. It originates from the radius and attaches to the distal ulna and ulnar carpus. Due to its location and function, the TFCC can be a source of ulnar-sided wrist pain, with injury classified as traumatic or degenerative. That was just an overview. Let's jump into some more detail. The distal radioulnar joint is formed by the articulation between the concave sigmoid notch, located on the medial aspect of the distal end of the radius, and the articular surface of the ulnar head. The ulna bone does not directly articulate with the carpal bones in the wrist. Instead, the distal end of the radius bone articulates with the scaphoid and lunate bones of the wrist. Here you can see the Triangular Fibrocartilage Complex, located between the ulna and the proximal carpal row, that is, opposite the lunate and the triquetrum. If we look at this illustration, we can see that the Triangular Fibrocartilage Complex is inserted on the fovea of the ulna by two triangular ligaments, as shown here. These are the styloid ligament and the foveal ligament. The distal radioulnar joint is stabilized by Triangular Fibrocartilage Complex and the joint capsule. The TFCC consists of the Fibrocartilaginous Disc and the Meniscal Homologue, the Ulnocarpal Ligaments on the Volar aspect, the ulnolunate and the ulnotrictural ligaments, the Dorsal, posterior, and Volar, anterior Radioulnar ligaments, each with a superficial and deep part, the Ulnar Collateral Ligament, Extensor Carpi Ulnaris tendon sheath. These anatomical structures together make up the Triangular Fibrocartilage Complex. Let's look at these structures closely one by one, starting with the Fibrocartilaginous Disc. The horizontal Triangular Fibrocartilage Disc proper is the main component of the Triangular Fibrocartilage Complex. As the name indicates, it is a disc-shaped fibrocartilaginous structure that extends from the radius to the ulna. The base of the disc is attached to the sigmoid notch of the radius, whereas the apex is attached to the fova at the base of the ulnar styloid on the head of the ulna. The central fibrocartilaginous disc continues medially and volarly to merge with the ulnar collateral ligament and the ulnocarpal ligaments, respectively. It is bounded by the dorsal and volar radioulnar ligaments and the most ulnar aspect of the distal radius. It serves as a cushion between the distal end of the ulna and the proximal carpal row, but does not itself confer considerable stability to the distal radioulnar joint. Next structure in the triangular fibrocartilage complex is the meniscal homologue. As opposed to the triangular fibrocartilage disc proper, it is primally constituted of fibrous tissue. Here it is shown as the blue highlighted area. You can better appreciate it in this diagram and can easily see that the meniscal homologue spans from the tip and lateral side of the ulnar styoid to the ulnar aspect of the triquetrum and base of the 5 metacarpals. It becomes almost indistinguishable from the ulnar collateral ligament and extensor Carpi ulnaris tendon. It creates a smooth arc that fills the distal ulnocarpal gap, creating a small synovial space between itself and the triangular fibrocartilage disc proper, called the prestyloid recess. Next up is the ulnocarpal ligaments, but let's first talk about the radioulnar ligaments that I mentioned before. Surrounding both the fibrocartilaginous disc and meniscal homologue are 2 ligaments calling the dorsal and volar radioulnar ligaments. Also called as posterior and anterior radioulnar ligaments. These ligaments attach directly to the radius bone, while the triangular fibrocartilage disc proper attaches into hyaline cartilage. This hyaline attachment is weaker than the opposite bony attachment to the ulna. Both these ligaments are reinforced by the ulnocarpal ligaments. The radioulnar ligaments are reinforced by fibers that connect to various bones, including the lunate, triquetrum, hamate, and base of the 5th metacarpal. Specifically, the ulno-lunate ligament and the ulnotriquetral ligament, as well as the ulnar collateral ligament, attach to these bones to provide additional support. So far, we have already talked about the disc proper, the meniscal homologue and the dorsal, volar, and ulnocarpal ligaments. On the medial side, the ulnar collateral ligament is found. The ulnar collateral ligament is superficial to the meniscal homologue and of limited importance. It is intimately attached to the articular disc. This ligament is located on the inner side of the wrist and helps to support the joint during movements that involve bending the wrist towards the pinky side. Lastly, we have the extensor Carpi Ulnaris tendon sheath. As I mentioned before, it is intimately related to the meniscal homologue. The extensor Carpi Ulnaris tendon sheath runs in an ulnar groove and appears to be an essential stabilizer of the ulnar side of the triangular fibrocartilage complex. There are suggestions that the triangular fibrocartilage complex is a vital pulley component to the extensor Carpi ulnaris, and that triangular fibrocartilage complex injury can lead to abnormal loading. Now that you know the components that make up triangular fibrocartilage complex, let's talk about its importance and function. Triangular fibrocartilage complex serves 3 crucial roles that I briefly mentioned before. The primary purpose of this intricate soft tissue complex is to confer stability between the ulna and radius at the distal radioulnar joint. So, most importantly, it stabilizes the distal radioulnar joint. How does it do that? Simple, as you have seen when we talked about the anatomical structures that make up the triangular fibrocartilage complex. They work together to stabilize the distal radioulnar joint. The dorsal and volar radioulnar ligaments encase the articular disc and create the distal radioulnar joint. The ulnar collateral ligament, the meniscal homologue, the tendon sheath of the extensor Carpi ulnaris, and the ulnocarpal ligaments intimately attach to the articular disc. This broadly based disc adheres to the radial sigmoid notch and extends to the ulnar styloid. The fibrocartilaginous disc also cushions the ulnar carpus, being responsible for 20% of axial wrist load. The bony morphology of these structures reflects an adaptation to the unique demands on this part of the wrist. While there is consensus that the dorsal and volar radioulnar ligaments primarily maintain distal radio-ulnar joint stability. However, there is conflicting evidence as to which provides stability during pronation and supination. During pronation and supination, there is the movement of the radius around the ulna. While the radial portion of the triangular fibrocartilage complex maintains is rigid, the ulnar triangular fibrocartilage complex and ligaments, that is the extensor Carpi ulnar and ulnar collateral ligaments, show dynamic changes that contribute to maintaining distal radius ulnar joint stability. As for the blood supply to the triangular fibrocartilage complex, it is supplied by the ulnar artery and it branches in the hand region, mainly the small dorsal and volar radiocarpal branches, and the palmar and dorsal branches of the anterior interosseous artery supply the triangular fibrocartilage complex. Blood supply originates from the surrounding joint tissues and variably penetrates the triangular fibrocartilage complex. Although there are different degrees of vascular penetration observed, the inner portion of the triangular fibrocartilage disc proper is considered avascular. The blood supply is limited to its peripheral zone and resembles the knee meniscus vasculature pattern. Another concept that you should familiarize yourself with when it comes to the triangular fibrocartilage complex is its physiologic variance. It is commonly called the ulnar variance. Ulnar variance affects triangular fibrocartilage complex thickness. Ulnar variance is the relative length of the distal articular surfaces of the radius and the ulna. There can be three types of ulnar variance observed in the triangular fibrocartilage complex. It can be neutral, having same length. Positive ulnar variance, where the distal articular surface of the ulna is more than 2.5 mm distal to the articular surface of the radius. Negative ulnar variance, a state where the ulna is abnormally shortened by more than 2.5 mm compared to the radius. The mechanism of injury to the triangular fibrocartilage complex is discussed by many anatomists and researchers. Often injured in forced ulnar deviation or falling on an outstretched hand. Common in athletes playing racket or stick sports. TFCC injury should be investigated following a distal radius fracture and wherever distal radioulnar joint instability exists. Patient who has triangular fibrocartilage complex injury presents with ulnar-sided pain that worsens with grip, rotation and weight bearing, clicking sensation on wrist movement, point tenderness between the pisiform and the ulnar head, and reduced grip strength. The positive press test can be executed whereby the reproduction of a painful sensation occurs by applying pressure on the wrist or by lifting one's own weight off a chair using the affected wrist. MRI imaging is useful for diagnosis of these injuries. Triangular fibrocartilage complex injury be managed by short period of bracing or taping to offload the TFCC. Avoiding repetitive wrist movements and aggravating activities is also recommended. While non-operative management is to be considered initially in stable injuries, surgical intervention should be a consideration in cases of instability and persistent pain of the distal radioulnar joint. Reports indicate positive outcomes in most patients following surgical management. That is all about the triangular fibrocartilage complex. Check out our related video here at sqadia.com.
Watch our medical videos anytime and anywhere. Download sqadia.com app now.